Hi, this is Bessie Burke. I'm a family nurse practitioner with Sun Life Family Health Center. We're a community health center system in Pinal County and part of Maricopa County. So we have 13 sites, almost 400 employees, 8 of which are sites are family practice. We have dental, we have a pediatric clinic, we have some women's health care clinics. So this is about our response to COVID and what we've done over the last year. So even though I'm the director of medical services, I still see patients 1 day a week. And I have been deeply involved with the whole COVID response. So the first step on that first week a year ago was, it wasn't real. This can't be happening. We've all practiced for events in our areas, for catastrophes, for natural disasters, and this is a real pandemic. We saw those original pictures from Europe as it started to hit New York. It just did not seem like it was going to do what it did. So first of all, we had to decide that yes, this was happening and we had to act. So we've had a crisis management plan for years. We've practiced it every year. We've done with our stakeholders in our county areas. We've gone through vaccine drills with flu vaccines, pretending it was some pandemic. So we just started that whole plan. That was our second step. Daily meetings, crisis management plan, everything on the table. So the first questions was, how much PPE would we need? How much do we use? How many staff was going to get sick? What was our call-in rate going to look like? How much was all this going to cost? Because you know what supply and demand looked like and what those costs did those first few weeks. Supply ran out and you couldn't buy a disposable mask for $10. So that was a huge issue those first few days, because we're a nonprofit. So we don't have millions of dollars in the background. So staff allocation was the first question. Who do we have and what can they do? And how do we not lay anyone off? That was our ultimate goal in the beginning, was not to lay off any staff, no matter what else. We had to close dental services except for emergencies because of the N95 mask shortage. So what we had to use sparingly. We had no way of disinfecting it. We didn't have light boxes yet. So nobody really knew how long you could wear them except all day. So we opened up our adult clinic and dental for emergency services. And then I had all of the dental staff. So what do we do with them if we're not going to lay them off? We trained them how to do all kinds of things. We had the most amazing group of dental service people. They did temperatures at the front door. They helped package up PPE into kits so that we would have gowns and masks and gloves in baggies that we could just hand people to put on. They did all kinds of phone answering services, answering questions. Some of the dentists had the right kind of credentialing to be cross-trained to help with COVID swab collecting. And we just looked at everyone's scope of practice in the whole company to make sure that we were using every last person that we could. And we did. We managed to not lay anyone off. So that was a big relief, because a lot of people in our company were their only income, and it's in healthcare, and originally they weren't going to be getting any of the extras in unemployment if we did lay them off. And also we wanted our people to have healthcare during this. If they got sick, if their children or family members got sick, we wanted to make sure that they still had their healthcare. So everyone needed to be working. So that first wave was kind of strange. You don't know if you're going to have one sick person a day or 50 sick people in every single pod. So the rates of PPE and predicting what we were going to need were very tricky. So we had those big screen tapes papers to the wall, just like we used to do in high school when you were formulating an algorithm. So that's what we did. We figured out how many sick people we could hold, what was the maximum capacity. And then we worked backwards from there to figure out how much PPE, changing your gown, gloves, every single contagious patient, what that would look like in the company. And then we figured out how much we had on hand. And our executive suite authorized us to have 90-day supplies. So we went and looked and shopped and talked to all of our supplies and vendors. And of course, we didn't get to the 90 days right away. That took several months to build up because you all know that you could only get a few boxes at a time from any one supplier. And we didn't have the type of money to just pay $10 a mask. So we had to be very careful. And then, of course, immediately you ran out of disinfecting wipes. So then you had to figure out some other way of sanitizing. So that's when we put our pharmacists to work because they're the real chemists in our organization. They figured out what hand sanitizer we could use, what disinfectant products from the CDC we were looking for, what strengths of those active ingredients would work against COVID-19 and still work against all the other things we have. We have a lot of cocci in our area. We have a lot of hepatitis in our area. So they wanted to make sure that we were getting a product that was going to cover all of those things because we didn't want a second wave of some other infection because we were busy killing COVID and we forgot to kill hepatitis. So we had to mix, we had to get the emergency use figured out. We had to write policies about it, how to clean with it, if you had to have gloves on when you handled it, every little detail. And then we couldn't get sanitizer in strong enough quantities to be a product that was going to kill off the COVID. I never thought I'd see a barrel of alcohol in the pharmacy. That was a first when we went to a distillery and bought alcohol. So, because our pharmacists can actually denature it. So they denatured alcohol and we started mixing up hand sanitizer in glass bottles because you couldn't find plastic bottles that were thick enough. So we had glass pump bottles with very short expiration dates because there's no preservative when you make it yourself and it has a very short shelf life. So we mixed all that up into sanitizers. We gave it out to our patients that needed it. We put it in all of the clinics because you can't refill those wall dispensers. That's not allowed. So we had to mount these bottles where they wouldn't get knocked over. So lots of Velcro, lots of ingenuity later. We got it all done. So then we got through that first wave and then we just got the funding for the testing blitzes started. So we decided to do our testing blitzes when we first got funding in July to help with this cost of staff being on overtime. And our very first one, instead of having a cloudy, stormy day that was predicted, it was 110. So of course, why not do it 2 more times in August? Because we're on a roll. Then we got smart and we decided to start doing walk-in and curbside testing at multiple sites so that we had more control over the timing. We could do it in the mornings when it was cooler if they were in their cars. Because a lot of our folks don't have air conditioning in their car. And we got some overheated people. Those giant tents, we had them up in parking lots. We started having walk-in times in some of our rural clinics so people could just come inside in the air conditioning and they had part of the waiting rooms blocked off to try and keep the contamination rate down. So we did all these testings at all of our sites as nurse visits. Then the second wave hit. We were a little better prepared because we kind of knew what to work with. We had our 90 days stockpiled. We were good little squirrels. Everything was accessible. We had already done this once, so we had a plan. So we started doing mass curbside testing. The very first day, we had over 100 cars snaking out around from our facility and down the street. And we realized that we needed some security help with traffic control. We had not thought that that was going to be the response we've gotten. We started our flu vaccination campaign about that same time because every organism we could prevent is what we wanted to get out into the public. We need a healthy community that is ready for that wave to hit. And if you have the flu, when you get COVID, those outcomes are not good. We've got distribution, some masks that were allocated for patient use only that we could give away at the front entrances in all of our sites. So our procedures were up to date from that first wave. We were still doing weekly CDC updates generated to all the staff members. So everyone was up with the latest changes. We knew that you had to have a mask to come in our building. We knew you had to have your temperature checked. Employees included, even the delivery people. If you walked through our front doors, you had to do all those things, even if you were only going to be in the building for 30 seconds, including all of our pharmacy sites. We were doing daily meetings with the crisis response team to stay on top of everything. So we just carried forward our plan that we had practiced for all those years. We kept the same identifiers. We kept the same scope of practice for each person on the team. And it worked because we got to vaccines. So when they started talking about vaccines going into Christmas actually getting delivered, it was amazing. So we had all of our staff was pretty much lined up ready because we got ours the day before Christmas. We started working with our stakeholders, the county health department, to coordinate services. We had been all along so that we were doing screenings and testing on different days than they were. We tried very hard not to be duplicating services. And that carried into vaccines. So we started working on our pop-up outreach vaccination ideas, working around what the county health department was doing at their sites, because our county did not go with the pod system that some of the larger counties in Arizona did. We went with our original vaccination plan, being provider sites. The city managers and the mayors offered up locations, started giving floor space, because we couldn't put 500 people a day through a vaccine clinic in any of our routine clinics, because our family practice has, 4 to 13 providers in it. So there might be 500 patients just seeing those providers. And you can't put 500 more for vaccines and expect to keep people 6 feet apart, because we still had to go through all the social distancing. And then the FEMA volunteers started showing up. A lot of the mass vaccination sites were using them. Our county was so fortunate to have some allocated to us. So when the county health department didn't have something going, we could use the volunteers. So that made a huge dent. There is nothing like having 10 people show up that can do vaccinations, and you just have to do the paperwork part. So that meant that instead of vaccinating 200 people, we could vaccinate 500 people. So numbers started growing. Taking a deep breath, we went on to continue with our staffing, having dental not at full force yet, having them working on the PPE, going through inventory, keeping track of the expiration dates on all that PPE, because we know that those expiration dates got extended, but not forever. We were still doing testing, even with vaccines. So the first 6 to 8 weeks of vaccinations, we were still doing hundreds of COVID swabs at every event. So the data that we have as of April 30th, we've done 25,100 vaccinations since Christmas in our poor little health centers and spaces that the different city mayors in our county have allocated for us. to do pop-up clinics. We've done all of this with phone system scheduling. We have a big barrier in our county with English second language and elderly populations not being able to navigate those web-based systems for scheduling. So we did ours with phone calls. We had a COVID phone center. We actually increased our employees to cover that. So we hired on per diem staff and we started answering the phone. Option 1, when you call our clinics, the first thing it tells you is if this is COVID, call 1. And we scheduled 25,000 vaccinations in that time frame, along with calling 9,240 COVID swab results. As of the end of April, our average positivity rate was down under 5%. We peaked at 32% in November. We've done 528 COVID antibody tests. 40% of those have been positive. We expect that, of course, to go up as time goes on and people start to get more testing. So we were never in a position where we laid off a single employee. The dental offices were closed, except for emergency care, for a total of 3 months. There were no other closures. We are now at 95% of our pre-COVID in-person visit rate. Only 5 to 10% of our visits were ever televisits. And we were able to do the phone visits to areas of our county that did not have enough data range to have a televisit. So we never got below 80% capacity in our visit scheduling. We had 1 week that was actually higher than our 2019 rate, which was kind of a surprise. So looking back, we were successful because we followed our plan. That's the plan we've used and practiced for a very long time, and that's the one that worked. We worked with all of our stakeholders. We kept in contact constantly with the health department. We all have each other's cell phones at this point. Our next looking forward process is in-home vaccinations. We've applied to be a vaccination provider for homebound patients and community members, such as small group homes or elders being cared for by family. People are not looking at those smaller entities that are out there because those are high-risk patients. Their family members and their caregivers are going in and out of public places and can very well accidentally bring home COVID, even if they are vaccinated. So what will it look like if we have to do a booster for all of these people? Our county is bordering on 40% vaccination rate. And if we have to booster 100,000 people in a relatively short period of time, what is that going to look like? So we're already working on plans with the county health department. Can we figure out how to do that with a massive flu vaccines, giving them the shots at the same time? And I think the masks are going to be here forever. That has no bearing on the future. I think we need to get used to them because epidemiology-wise, it's going to be a while before this virus is down below that threshold in our population to where it's safe to ignore. So we're all in this together and we will not fail. Our communities are surviving. Ours is prospering quite well. And I am just so grateful for the hard work and the team approach that everyone in our county has taken. We've all worked together and we've all made this a success, coming out on the other side with our people healthy and well and cared for. If you have any questions about how the process is or who we talk to get permission to do what, feel free to email me because there has been a lot of hoops to jump through. It sounds simple on the slides, but whenever you're dealing with the CDC and HRSA and Joint Commission and getting privileges to do things, it's a little more paperwork than you ever thought. So thank you for listening, and I hope you enjoy the rest of the conference.